Good evening, everyone. Thank you so much for joining me for another episode of my COVID recovery series, where I speak with people from around the world who have recovered from the coronavirus in an effort to share and spread some hopeful stories that would inspire all of us. And also movers and shakers from around the world who are fighting the good fight on the front line of this pandemic. Now tonight I want to speak about a topic that's very close and near and dear to my heart. I want to talk about refugees, vulnerable people living in war-torn countries and living in communities that have taken them in as refugees. Today in the world, there are over 70 million refugees. And as many of you may know, Syria and Yemen today are the two worst humanitarian crises of our time. Now, as we go through the coronavirus pandemic, and as hard and challenging as the situation may be for many of us, there are people, millions of them worldwide, who are suffering more than what we can imagine, more than what we can feel, with so little help and support. Now tonight, we want to talk about this very important topic, but also find out ways that you can help support the refugee community and war-torn people and families at this very critical time. That's why it is my absolute pleasure to have Dr. Zaher Sahloul join us tonight. Now, Dr. Sahloul is a Syrian-American critical care specialist. He's also an associate professor of clinical care at University of Illinois in Chicago. He's also the president and co-founder of MedGlobal, an American NGO that travels globally to war-torn countries and conflict zones and supports local organizations in an effort to provide adequate, sustainable, but also honorable and respectful medical care to those who need it the most. So it's with my absolute pleasure to welcome Dr. Sahloul, who will be joining us from Chicago. I also want to mention that Dr. Sahloul himself contracted the virus and recovered. So he's going to talk to us a little bit about that and more. Let's bring Dr. Sahloul into the conversation. Hello, doctor.
Hey, Sarah, how are you?
How are you? It's so good to see you.
Good to see you. I hope that you're staying healthy, and thanks God for your recovery.
Thank God for your recovery as well. My goodness.
Thank you. Welcome to the club of COVID.
Thank you so much. Thank you so much, you know, for really always being an inspiration. I mean, you help people, you know, in war zones and in conflict zones, but here at home, you know, you work with patients day in and day out, but also, you know, you recover with confidence and grace, really. So how are you doing?
Much better. You know, I recovered about 2 weeks ago, back to work. I still have some fatigue, maybe 80%, I would say, in terms of stamina. I did not recover my senses of taste and smell yet. That takes a few weeks, I heard. But overall, I'm doing much better.
Good.
How about you?
I'm much better. I got the virus end of March, beginning of April. So I'm now slowly recovering my sense of taste and smell. So I can tell you that it will come back to you, but it would take.
That's great news.
And you contracted the virus while treating COVID patients. Am I right, doctor?
Yeah, I mean, I don't know which patient, of course. I mean, in my hospital, we had hundreds of patients that I've treated or participated in the treatment. And it's very difficult to say that I contracted this virus from this patient. It could be just from a colleague who had no symptoms. It could be from a patient that we did not suspect them to be COVID, but they end up being COVID. It could be from asymptomatic person. So who knows? But, you know, clearly we have many patients with COVID, and this is part of the job.
the
I
job.
mean, I was not happy because I was not able to work for 3 weeks at the peak of the pandemic. But many physicians and nurses in my hospital got infected, unfortunately.
Do you think let's talk a little bit about your work in Chicago, and then we're going to go and talk globally because I certainly want to touch on the issues that are very close to both of us. But talking specifically about Chicago and the hospital that you're in now, would you say that there were enough PPE? Were there enough equipment? Did you feel comfortable going to work?
No, I mean, definitely we have until now shortage of PPEs. So yesterday, I mean, I was rounding in the floor in the COVID floor. We have 6 COVID floors in the hospitals, 2 intensive care units for only COVID patients, and 4 are for non-intensive care unit patients who do not need to be on the respirator and so on. So I wanted to have the eye shield. The PPEs, just for people who are not familiar with that, are protective personal equipment, and they include in the patient of COVID the N95 mask, the mask that will not you will able to, of course, inhale air, but not the virus, and it should have a good seal on your face. The eye shield or goggle, the gown, and the gloves. I mean, these are the 4 pieces of the PPEs. We have shortage of the N95. We have shortage of the eye shield. And that's in a hospital that is tertiary center in Chicago that has 800 beds, well resourced. So imagine the shortage in smaller hospitals. And definitely that is adding more stress to the physicians and the nurses, especially the nurses, because they spend more time with the patients.
Of course. No, that's terrible. I read in an article that you compared the situation in your hospital to scenes that you've seen in Syria. Tell us more about that comparison. What made you feel like that? Because as I said earlier, you spent a lot of time worldwide in conflict zones and vulnerable communities, and making that comparison is very telling, Doctor. Why did you make that comparison?
I mean, for 5 reasons. The first one, that disasters are disasters. Whether it's a war in Yemen or Syria, whether it's natural disasters like Hurricane Maria that affected Puerto Rico, whether it's now a pandemic that is overwhelming the medical system. So when you have a major disaster, we call it class 3 disasters, that you're not able to save everyone's life. That means you have to make adaptation in a way that you think as a physician or a nurse or administrator, in a way that you direct your resources to save the patients who are more likely to live. And you know that you're not going to be able to save everyone. So that happened in Syria. It happened now in Chicago and every other part in the world, in the UK, of course, in Spain, Italy, and China. So it's overwhelming the system. That means you have more patients that you can save. In Syria, I remember, in Aleppo, when I was in one of the missions, that, after a bombing, you have an influx of victims of bombing, barrel bomb. You have 40, 50 patients who come to the emergency room. You don't have 50 surgeons who can take care of them. You don't have 50 ventilators or respirators. So you have to make difficult decisions. So this ethical questions that comes to mind in the time of COVID, in time of war, which patient I should be directing more attention to, and which patient I should maybe let go because I know that I'm not going to be able to spend 8 hours trying to save their lives. In the peace situation, you will be able, but in the disaster situation, you won't be able. So this switch in your ethical thinking is, of course, very similar. The amount of stress that healthcare providers go through because of this situation, because that they have to make difficult decisions, because they are working 12 hours a day, because they know that sometimes there's no light at the end of the tunnel. We've seen that in Syria and Yemen, that doesn't look like there's stopping the bombing. And the same thing with the pandemic. The virus will stay with us for a long time. It doesn't look like we're going to have a vaccine soon or a medicine soon. That's another, of course, parallel. And the last thing is the decision making. When you have policymakers who are not able to stop the bombing on Syria and protect healthcare professionals, and also who delay in implementing preventive measures, lockdown and social distancing and so forth, testing in the United States, it brings a lot of similarities. Until now, we're not able to protect doctors in Syria because of the bombing, and also we're not able to protect nurses and doctors in the United States because of the shortage of PPEs.
Of course. No, the situation is very grim, but in the program, I try to find solutions, or at least moments that you have encountered, or other guests have encountered, that can show us that glimmer of hope. And of course, we don't want to pretend that the situation is going away anytime soon, or that there's a solution for it. But what do you think can help this overwhelming conditions that we have in the hospitals, aside from change of policy and all of that, but from the medical community, or just from the society? What can people do to help each other in absence of a strong policy, in absence of support from policymakers? What can we do to help each other?
I think people in general now, 5 months into the pandemic, are more aware, of course, of the virus. People who spreaded the conspiracy theories in the beginning that this is nothing, this is a flu-like, and so forth, now are aware that this is a serious virus that is causing death among many people. I mean, in the United States, we have close to 80,000 people who died. So states, and that could be a mom, a dad, an uncle, a relative, a neighbor, and so forth. So it's serious. People are taking it more seriously. The social distancing concept is becoming now more common among people. They understand that how the virus behaves, how is it spreading, washing hands, wearing masks in public, not going into big gathering and mixing with the group. So people understand that. And the medical community also have adapted to it. So we're not panicking as in the beginning. We know what to expect with the patient. We also changed the way that we are treating these patients. In the beginning, we were very aggressive in putting them on respirators and doing all kinds of stuff, technology that may not necessarily be helpful, because respirators by themselves, mechanical ventilation, can cause harm to the lungs and to the patient. So right now, we know how to deal with these patients, maybe take it easy a little bit, giving them oxygen, giving them supportive care. We know what not to give in terms of medications. Hydroxychloroquine, for example, we don't give it anymore.
Yeah.
Yeah.
Of course. I want to talk about an issue that's incredibly important to me, and that is mental health. You mentioned, in one of the articles that I read recently from you, the amount of trauma and PTSD and mental health vulnerabilities that healthcare workers, doctors, nurses are enduring, not just in the US, but of course around the world. Do you think this can, in a way, be a blessing in disguise, that moving forward, because of this pandemic, we are going to see more attention being given to mental health in general, because now more people, including physicians and doctors, are being vocal about it?
I mean, I hope so. I mean, I know, Tara, that you have an NGO that is providing assistance in terms of mental health to Syrian refugees and other refugees in Lebanon, which is something that is unique. There's a lot of talk about mental health, but not many people help in addressing this issue, whether among vulnerable population like refugees and displaced people and victims of wars, or among healthcare workers. I mean, I just give you an example. Last week I provide coverage in 2 hospitals. One of them is the big tertiary center, and one of them is a safety net hospital in Chicago called St. Anthony's. It's a small hospital, has 15 ICU beds. They don't have resources like the big hospital. Patients' population are different, more death. They are more overwhelmed. So I went to the ICU to round, and then I asked one of the nurses, "How are you feeling?" And she's a young nurse who started to be in the ICU about 2 years before. And she started crying. Just out of blue, she started to cry, and she said, "I cannot take it anymore." people have feelings, and you don't know what to do in these circumstances. But nurses in particular, and of course less than that, physicians are overwhelmed. They're taking care of very sick patients. It's very demanding in terms of what they need. They spend 3-4 hours every day with every patient. And if they are taking of 4 or 5 patients in the ICU, I mean, that's very overwhelming to any person, even the ones who are trained to take care of sick patients. So we have to identify, first of all, that this is a problem. And I'm happy that yesterday the WHO have talked about this issue, and they said that there's 30% increase in mental health problems related to the COVID, and maybe directing more resources to do that. Every hospital administration has to direct more resources in terms of addressing the mental health within healthcare workers.
I think that's so important, and I really, really hope that, you know, we take this moment as a reminder to pay more attention to this, because I think the pandemic is just reminding us that this is present, because before it also existed, you know, whether it be in US or elsewhere. So hopefully there will be more attention and resources given to mental health. Now let's move to let's move outside of the US. Let's go to countries that unfortunately don't have the resources that we do here in the US or Europe. We can talk about this for hours, and please correct me on the numbers, but you know, since 2011, as you know, the viewers know, Syria has been going through a horrible civil war, a conflict that has ravaged the country. We have more than 5 million refugees in neighboring countries of Lebanon, Jordan, and Turkey. We have nearly 16, out of the population of 16 million, 12 million are in need of dire humanitarian aid, and now nearly 7 million people are internally displaced, with 1 million just this past February in northern Syria. So we're talking about millions of people who are one way or another being affected by almost a decade-long war, who have very little access to medical care, health care, and really basic needs. Dr. Sahloul, you've spent time in Syria, you spend time in makeshift hospitals, and you know, you and I both know that over the years, doctors, medical facilities, and hospitals have been directly targeted and attacked and bombed. So the situation is really bad. But unfortunately, I really want to emphasize on this, unfortunately, the population there is more so at risk of contracting COVID and not getting the support that people elsewhere in the world get. So can you please talk to me about what's at stake? What are we facing right now in Syria?
I mean, as you mentioned and stated, when you have a country that is going through a war for the past 10 years, now it's the 10th year, with a huge displacement of the population, half of the population displaced. In the province of Idlib, which you've mentioned, there was a recent displacement because of the relentless bombing of the Syrian and the Russian regimes in December, January, that led to 1 million people newly displaced now. I went actually to Idlib in January, at the beginning of the COVID pandemic. At that time, it was limited mostly to China. And I've witnessed the camps for the displaced. You have 1.2 million people crowded in 1,250 camps. And these camps have sometimes 50 tents, sometimes they have 500 tents. So imagine if COVID virus spreaded in Idlib, where you have all of these camps that are very crowded, very densely populated. People do not have facility even to wash their hands with water and soap. If they want to wait for the food line, they will have to be long line of people who are crowded also. The concept of the same thing with the washroom. You have one washroom for 70 people. So imagine if you want to enforce certain social distancing in a camp.
It just doesn't work.
It's impossible. It's impossible. So you have to do it different ways. Luckily, and I don't know if this is real numbers. So far, we have not seen any case in the Idlib province of COVID-19. They tested about 400, 500 suspected case, but so far the test came back negative. It could be that they are not doing enough testing, which
But do they even have sufficient testing, though? Do they have enough testing in Syria?
uh, in Syria, of course not. I mean, Syria,
Course.
Gaza, yeah, they do not have. I mean, United States does not have.
That's what I'm saying. So how can we even rely on these numbers? I mean, how are people even getting tested? It just doesn't make sense.
We cannot rely on these numbers. Of course, people could be dying at home. The concept of going to the hospital in a refugee camp is not an easy concept. So most times people who got sick, sometimes they just die in the camp. Of course, no one knows whether they have COVID or not. The same thing, patients with chronic diseases who end up having a heart attack or a stroke. I mean, the concept of going to hospital or ICU, intensive care unit, is not very common in some areas.
Sorry, but I think this is a question that I really want to be clear on. Do you think that the COVID crisis can be widespread inside Syria and we just don't know about it?
Definitely. I mean, many people think that we have more numbers of COVID. If we talk about whole Syria, the government said that there's only 48 cases of COVID. I mean, it's impossible. I mean, I spoke with doctors in Damascus who told me that they've seen many patients who died in the biggest hospital in Damascus. But it looks like this, all of these reports of numbers of cases in some countries are politicized. Some countries are inflating the numbers because they want to have some political gain. And some countries are reducing the numbers because they also want to tell, their followers that, we're doing a great job in Syria. So you have maybe close to 100,000 cases in Turkey, which is just north of Syria. You have many cases of COVID in Lebanon, which is just west of Syria. In Iran, more than 100,000 cases, which is very close to Syria. There are many Iranians who are traveling to Syria, whether religious or fighters. So it's impossible that you'll have only 48 cases in Syria. And most of the authorities think that these are huge underestimates of the real problem.
Oh, absolutely. And that takes me to Yemen, and not, a country of 28 million where half of its health facilities are pretty much shut down. And, millions of people, again, are displaced and are at risk of famine and so on. And we are seeing reports of COVID cases, and WHO just issued a warning that if this continues, we're going to have a huge humanitarian crisis. So very similar to Syria. And then it takes, we can go to Cox's Bazar in Bangladesh with the, million Rohingya refugees, where today they shut down a block, a place where you and I both seen that Rohingya Muslims live in very, very tight, cramped areas. So I guess the biggest question is, right now, people are not thinking about refugees. People are not thinking about people who are, living in these conditions, because we are so occupied with our own issues and dealing with COVID. What do you say to those people? And what's at stake if we forget about these people right now? What's at stake?
I think we have to address it from a different perspective. First of all, you're very right in worrying about Yemen. There's 70 cases now in Yemen, and when you reach the number 100, usually the rate of case accelerates, as we've seen in other countries. So it's very close to 100. There's 12 deaths in Yemen. Yemen is very poor countries. I was in Yemen 6 months ago with a group of 22 physicians. We were providing training, we're providing medical supplies and technology to Yemeni physicians. Right now, we are in MedGlobal, we're doing also COVID response. We're providing PPEs and medications and medical supplies to different areas, including Sana'a. Yesterday, it was a milestone for us because we were able to furnish one of the quarantine centers in Sana'a, the capital, with medical supplies. Hopefully we'll do more of that. But Yemen is a country that is underdeveloped even before the war and before the crisis. Huge shortage of everything. Rohingya population you mentioned. Yesterday, there were the first 2 reports of 2 Rohingya refugees who contacted the virus. And they are very densely living in a small area that you've seen in Cox's Bazar. More than 750,000 people crowded in very small area. So the consequences will be catastrophic if they have only 6 ICU beds for all of these refugees in Cox's Bazar. So as a humanitarians, you and me and people who care about humanity, we have to care about the most vulnerable, the refugees, the displaced, the victims of wars, patients in low resources countries, patients in our countries, in the UK and the US, who are affected more with the crisis. You know, in the United States, African American are 70% of the death related to COVID because of the comorbidities and the lower access of healthcare. So we have to care about healthcare disparity and the victims who no one pay attention to. But also from, I would say, health security perspective, you have to care about the most vulnerable, because if you have tens of thousands of or hundreds of thousands of displaced people infected, they will infect other people also in the host communities, whether it's Bangladesh or Europe or other places. So that's why we have to pay more attention. We tend in a time of pandemic to be more self-centered. That's normal reaction, governments and hospitals. But unless we care about people who are less fortunate, then it will come back and haunt us.
Exactly. No, absolutely. And that takes me to MedGlobal. You've been involved with many organizations that provide medical support to vulnerable communities over the years. But recently, in 2017, you started, along with a colleague of yours, MedGlobal. Tell us about MedGlobal and the projects that you're involved with right now. You mentioned your accomplishment in Yemen, which is significant because I know how difficult it is to get anything into Yemen right now, and of course your work in Syria. And finally, tell us how people can help. You know, viewers who are watching right now, how can people help MedGlobal? How can people support?
I mean, thank you. This is a very dear thing to my heart. You know, a few years ago, I was with Dr. John Kahler in Aleppo. That was in 2016. At the peak of the bombing at that time, Aleppo was under siege. And we went there with another physician from Chicago. Dr. John Kahler is a pediatrician from Chicago also. And there was only one road leading to the city, was being bombed, were snipers. Miraculously, we were able to get into the city. We treated patients in underground hospital. We've seen many victims of war, mostly children, civilians. I mean, the pictures of these victims of war are still very fresh in my mind and Dr. John Kahler's mind. We were able to leave the city right before the complete siege. So it was miraculous, I would say, exit from the city. We were the last foreign volunteers who were able to get into and out of the city. And at that time, you know, I felt that, you know, why would Dr. John Kahler come to Aleppo and endanger his life for Syrian children? He's a pediatrician, 69 years old at that time, from Chicago, because he believed in humanity. He believed in giving to the people who are victims who no one pay attention to. Right. And that idea was planted in my mind. And Dr. John Kahler, I approached him in 2017 to start this organization to reduce healthcare disparity, focusing on disaster region. And right now we're on 14 different countries, including Yemen, including Gaza, including Syria, including Bangladesh, Pakistan, Venezuela, Colombia. We're providing medical assistance to the local community to make them more resilient. We're providing technology and supplies and medications. We're doing training to healthcare providers. So the way to help MedGlobal, if you like what we do, we provide healthcare to areas that are ravaged by wars and disasters, is by donating, of course, and volunteering with us and spreading the word as you are doing. You can go to our website, www.medglobal.org. You can donate wherever you can. So that will help into saving many lives. And that's the way it works. You know, in Gaza, for example, we sent PCR machine, we sent test cartilage just last month, and they did 6,000 testing because of the PCR machine. So everything that you donate will be translated into value in areas that are deprived of healthcare. We have abundance in the UK, in Europe, in the United States of everything. Other communities do not have that much.
No, absolutely. And I think there are many reasons why I admire you, but one of the reasons is the fact that you, like myself, want to empower locals. It's not about donating or helping. It's about empowering people who at that moment may not have the sufficient requirements or equipment or necessities to do what they need to do, but they're certainly capable and able to do whatever it is that we can do here. And I think the reason MedGlobal is very effective is because of its partnerships on the ground with local groups, with local NGOs, with stakeholders who know the communities well and directly work with the people. And that's the difference between your organization than an INGO or a large organizations. And this is for the viewers who are watching, as someone who has seen the work of different non-government organizations and large UN entities. There's a big difference of supporting smaller organizations like MedGlobal that are working on a grassroots level, because the support directly impacts the people on the ground. So that's incredible. And for whoever wants to donate or contribute or volunteer their time, the website is www.medglobal.org. Is that correct?
That's correct.
Okay.
Thank you, Tara.
Thank you so much, Dr. Sahloul. I'm really glad to see you, and I'm really glad to see you're safe. And as always, thank you so much for being a strong advocate for people who don't have a voice or their voices are not heard. Thank you.
I'm looking forward to read your book, though. So let's.
Thank you. Next year. That's postponed too, like many things. I'll have a copy for you. I really hope to see you in person.
Yes, hopefully maybe in the next couple of months when things get back to near normalcy, maybe we can meet in New York or London. I love London.
Absolutely. Yeah. Thank you so much, Doctor. And thank you for all the insight. Thank you.
Thank you. Thank you.
Bye-bye.
Bye.